Here he is. So we're going to talk about the PBC Care Bundle. We'll probably talk about the audit that led to that. So we'll give you just some of the, and then the idea is that this will be an interactive discussion. Okay, we might open it up to Q&A. You might have had enough and are desperate to get home. So we will go through it. But what we're doing firstly is just making sure that everyone has the two main documents that we're going to discuss. That said, we don't have the two main documents we're going to discuss, so I will go and get that. So I'll hand you over to George, who's going to start this session, and then George and I'll do it together, and we'll talk about where we are and hopefully some solutions. Okay? I'll get the documents. You want them?
When I'm even deeper into it. No, that's
Oh, God, they're probably on my laptop or something like that.
No, I thought they
Oh, you've got them?
I'll just email them to both.
Okay. Okay, just to make Andy's life complete, we're going to bring up a stick and get a couple of slides because we think that's going to be helpful to the discussion, to the presentation. So do you all have these two documents in front of you? What we have, all right, they're coming. We just need to know who's got and who's not got. So we have the A4, which stays A4, which is the patient guide to an appointment preparation. And then we have the funny size, which goes down into A5, which is discussing PBC with your clinician. So these are the two documents that we're going to be discussing. So they are coming round. So again, this is a document that we've put together in response to a demand, a request. And we've done it in a way where we listened to the unmet need. We put together a draft. We then ran that draft through a bunch of patients who had been diagnosed for different periods of time. So therefore had different lived experience and perceptions of the issues at hand. And they then gave us our feedback. Are we changing laptop? Cool. That's fine. Oh, nice.
Wonderful. Thank
Are you good?
Mhm.
So we've got about an hour on this, but we'll try and close up earlier so we open up the questions.
So this we're just going to talk actually about two things, that, Robert and I this afternoon, about a care bundle and about this project 1990. And just before we get on to an explanation of what those are, I just want to show you where it came from. So you've seen this slide many times today, and as you've heard me say several times, this is a care pathway from the current BSG guidelines on the treatment of PBC, which has got these pillars of care. But in addition to these pillars of care, the BSG actually recommended, based on this, certain quality standards for the treatment of PBC. So, for example, 90% of patients should be receiving ursodeoxycholic acid at an optimal dose. 90% of people who have not achieved an adequate response to ursodeoxycholic acid should have been referred to second-line treatment. 90% of people who need to have ultrasound scans for surveillance of cirrhosis and so on should be receiving it, and so on. Okay, so they've got a set of quality standards, and there was a suggestion based on a lot of information, anecdotal information, publications from the PBC Foundation, that the delivery of PBC-related healthcare in the NHS was not really achieving these standards. So on the back of that, a team of people did this national audit of PBC called the UK PBC Audit, which ran from 2021 to 2022. Most centres throughout the country participated, and in fact, information was gathered about more than 8,500 people in the end who had PBC. So we had a very good idea about what the standard of care that was being delivered across the country. And you can see here a summary of the results. So this is the audit standard, which was 90% for each of the quality standards that was being tested. You can see that actually more than 90% of people were receiving first-line treatment with ursodeoxycholic acid, so that's good. But in fact, only about 60% of those people were receiving the correct dose. And then all the rest was not particularly good, actually. Only 51% of people who were eligible for second-line treatment had been referred to a centre to receive that. Only 62% of people had been asked about their symptoms in the previous 2 years of attendance in their appointments. Only 55% of people had had some kind of fracture risk assessment, which is relevant. As we discussed yesterday, people with PBC have a higher risk of osteoporosis. Only 70% of people who should have been having regular ultrasound scans were getting those regular ultrasound scans. And only 60% of people who should have been referred to a transplant centre because they had developed liver failure had been discussed with those centres. So these were pretty poor results. And on the back of this, there was a feeling that that we needed to do 2 things. The first being to really emphasize the need to achieve these 90% standards, and that's where 1990 comes from, the idea that any given individual with PBC should have achieved 90% of those standards, and any group of people with PBC, that 90% should have achieved any one of those standards. I think that's the correct interpretation.
They're close enough.
Something like that, something like that. And then we needed some means of providing clinicians essentially with an aid memoir about what it is that we're meant to be doing. And that aid memoir is a care bundle, basically. So in fact, a care bundle was generated. It's a 10-point plan, in essence. It consists of a list of 10 things that should be done for a patient with PBC. Are they receiving first-line treatment? Is the dose 13 to 15 milligram per kilogram? Have the bloods been looked at, and have they been referred for second-line treatment as appropriate? And so on and so forth. And that has been piloted, that care bundle has been piloted in a number of centres. The care standards have been re-audited in those centres. And I can tell you now that, in fact, use of a care bundle does dramatically improve performance. So we think the care bundle works, but also, in addition to providing a care bundle to clinicians, the PBC Foundation has come up with a patient-friendly version of the care bundle. And Robert, I guess you want to tell us a little bit more about that.
So, yeah, to share. So I think, and again, credit where credit's due to George, who has been part of the leadership team of this. And one of the biggest advocates of saying, actually, the care bundle for clinicians is one thing, but let's make a patient-friendly version as well, so that patients can be empowered, informed, and confident enough to have these conversations. So thank you for that, because that gave us the confidence. We know that the clinicians would be open to this. Because if we put something together where you're going to face a barrier in the appointment, then there's no use to you. So, but we know that clinicians are going to be open to this, and we can tell you that as a main, this will be helpful in your conversations and not controversial or argumentative or any of those kind of things. So what we did was we took the 10 questions and we took out most, not all, but most of the Latin and Greek, and just made it really, really simple. Okay. So the idea is that wherever you are on your PBC journey, you can go through these and then tick the tick box. Is it helpful to go through one by one? Okay. So number one, have I been prescribed Urso? Really simple, yes, no. Okay. Number two, are you on the right Urso dose for you? So we know that Urso is dosed at the dose of. That's not bad. Would have been better on the Saturday morning, I think. But okay, right. So yes, but 13 to 15 mg per kg. Or if you're in the US, just to mince with your brain, you are on 6 to 7 milligrams per pound. Go figure. So, are you on the right dose? And then, do you require second-line treatment? And more importantly, are you getting a second-line treatment? And hopefully the information that's been provided today, you are much, much more informed in terms of the way that you can get second-line treatments, and that the second-line treatments are coming onto the market that are going to be available to you. Have you discussed the following symptoms with your clinician? Itch, fatigue, brain fog, and dryness, which were the big four, again, that George highlighted. Now, this is really, really important, that sometimes, even though there can't be anything done clinically, for example, for your fatigue, to still have that conversation, still have it recorded, to still have it acknowledged. Now, great clinicians will say to you, there's nothing we can do for your fatigue. However, speak to the guys at the PBC Foundation and see what they can do to help you on your journey. And many of the clinicians will refer to us, and hopefully some of you got that way or through that pathway to us. But the idea is that you're in control, and because it's there in front of you, you're not relying on your memory, for one, but two, it gives you the confidence to say, actually, you know what, I really do right now need to talk about my brain fog, because it's a quality of life issue. And even if there's not clinically any interventions, there's still support and understanding and validation of that part of your journey. Has your bone health been assessed? Oh, I've hit something there, George, sorry. Again, it's important. It's awareness. If you know where you are, you know what you can do about it. Has your PBC been assessed in the last 3 years? So actually looking at liver cell change. If you have cirrhosis, if you had an ultrasound, and then if you have a portal hypertension, is your screening up to date? And then ultimately, where we're in the niche of the subgroups, again, I'll check the wording. Have you developed complications associated with cirrhosis? Okay. Now, most of the people will never need to get to 8, 9, and 10, but they're there in case you need to. Any thoughts or questions around that document? Yes, we'll get a microphone to you. I stole Linda's microphone, shamelessly. I beat her up with her own handbag.
I took my copy from Fairfax for my recent consultation.
Yep.
In June this year.
Yep.
I saw my consultant, and with her, there was a young doctor who was doing hepatology as her specialism. And she welcomed this with open arms and said that for the trainee, it would be an aide de memoire
Mhm.
for her future patients. She thought it was brilliant. So that was the
Fantastic.
copy from the centre of Fairfax.
So we need to send you a new bare fax now. You've violated the bare fax, right? Okay, which is great, and that's why we shared that. Say, hey, this is for you, but now we've got the standalone document that you can take and you can share and you can leave behind and you can do all those things. And thank you for sharing that, because again, that's experience that tells us that that journey is welcome. Val.
Yeah, what is portal hypertension and varices? Because a lot of people don't know.
George.
Yeah, it's something we touched on yesterday, actually. When the blood from the intestine, the stomach and the intestines, has to flow to the liver through something called the hepatic portal vein, through the liver into the vena cava, and then back up to the heart and the rest of the circulation. When the liver becomes scarred as a result of cirrhosis, it becomes much more difficult for that blood to flow through the liver. And so the blood in the portal vein, the blood pressure in the portal vein goes up, and the blood starts to, and new channels called varices form as a way of bypassing the scarred liver. So the portal hypertension refers to the increased blood pressure in the hepatic portal vein, and the varices refer to those bypass vessels seeking some other means of getting back into the rest of the circulation.
Thank you. School day. Right. Thank you. Any questions in terms of the document yourself? So a show of hands. If you're happy and comfortable to do so, would you feel happy, confident of taking this document in to your next appointment? Oh, okay, job done. You've been a lovely audience. We'll be here next. No, that's fantastic. Any questions? Yes, please. We'll get the mic to you. It's coming. Just coming.
Who was it?
Here at the front, Linda. Warmer. Warmer. There we go.
No, it wasn't us. That was
Oh, you still had your hand up? Oh, sorry. Oh,
I'll be happy to.
oh, sorry. My apologies. Trained professionals. All right. Okay. Fair enough. All right. Apologies. Okay. So you would feel happy and confident about doing that. Okay. So you now have the copy. Obviously, it's duplicable. Is that the word? But it's downloadable as well. So actually, so if you have the facilities to print for yourself, but if not, you can come to us. You can take as many as you want. Hopefully the volunteers will take them back in the suitcase. And we can get this out and prepare for this. Okay, so we've got another document to look at. Are there any other thoughts and comments on this document itself? You see where we've come from, how we've tackled it, the fact that patients have been involved in the creation of this, and hopefully we've given you a tool that you can now use to change your journey. Are you quite happy? Any thoughts or comments on that? I knew he wanted them. I just felt it in my bones.
It's a fellow gooner, that's why. I know, I'm just saying it's succinct, it's to the point, it's very easy to understand and very, it doesn't take much time to fill in. It's obviously a lot of thought was gone into it, and that's reflected in this. I think it's a superb document, and well done to all concerned.
Brilliant. Thank you. Okay. Appreciate that. Oh dear. Did that on the mic. Sorry.
So with PBC, obviously, it's important to monitor. My question that I always struggle with is, okay, so there are things like your blood work, ultrasound, FibroScan. What, and I talk to different people. Well, how often do you get your FibroScan? How often is your blood work done? Some people 3 months, 6 months. And I understand that it probably varies depending on the severity of your condition. But for someone maybe earlier stages, stage 1, stage 2, is there a specific protocol as to how frequently those different tests should be occurring or happening.
There are suggested frequencies, but they're not based on a great deal of evidence, and therefore it will be individualized. This care bundle is designed in such a way that it won't necessarily say it should have been 3 years or it should have been 2 years since the last FibroScan. It's designed in such a way that it will prompt the question just to make sure that whatever the frequency ought to be for you in that particular hospital, based on that local, based on the local resources and local experience, that it's been done correctly. So we can't be prescriptive because very often we don't know. We don't really know how often a FibroScan should be done. In Cambridge, it used to be done every 3 years. In some centres in France, for example, where there's a great deal of interest in FibroScans, it's sometimes done every year. I thought I was right. I'm sure they'd think that they were right. But the care bundle is designed in such a way that if you asked me, has my PBC been staged in good time, then I'd be able to think, oh, well, let me just check that. Oh, no, let's get another FibroScan.
So it's really pretty much, it's not something I can go in and say, well, I'd like to have this done or that done. It's really pretty much up to the physician,
No,
right?
you can. I mean, you can always say that you would like something done, and if it hasn't been done for a long period of time and the physician agrees with you, you get on and order that test for you. If they disagree, then they can explain why. But it is always meant to be a two-way relationship. It's never
right,
intended. The clinic consultation is never intended to be didactic, physician is teacher sort of thing. That's not the case at all.
Okay, thank you.
Although George is not bad at being a teacher, to be fair. I mean, George and I have worked for years and years and years, and what George has brought to the foundation has been incredible. And we've had discussions for many years on personalized medicine. The fact that you should be on the right medication for you. You should have the right monitoring for you. But personalized medicine isn't perfect either, because you get then these differences. Should I be scanned this or should I be scanned that? But the other thing to bear in mind is there are two parts to a consultation. There's the actual physical part of your PBC, but then there's the emotional and psychological part of managing the anxiety around the PBC. And so there may be people who don't need a scan every year in PBC terms, but because maybe it's early in their journey, or because they're maybe starting a new medication and are aware that they want the changes to happen or not, as it may be, they need that scan again for reassurance. And I think, again, as patients, be honest and open about that and have that two-way conversation with your clinician. Okay. Please.
Probably should have asked this question before, but I wasn't quite sure. This is my last chance to ask something, isn't it? So I know we get bone and joint pain, and we know we can do various tablets. But a lot of people they say, my liver's hurting. Now, I also know, of course, that the liver hasn't got nerves, but is there not a sac around your liver that can get inflamed? So if you've got a pain sort of where your liver is, do you not take it that you need to see somebody about that or not?
Well, it depends really on how long the pain's been there, actually. You are right that liver pain can happen in PBC. It's not pain from the liver itself. It is, as you say, probably from irritation, inflammation, stretching of the capsule that lines the outer surface of the liver. If a pain is new and troubling, then that is worth asking about sooner rather than later. If the pain has been there for a very long period of time and it's never evolved and there are no associated symptoms with it, and it's been discussed before, then it can probably be attributed to the PBC and wait until the next consultation to see what else could be offered for it. But I'm afraid I can't give you a fixed answer to that, because it really does depend on when the pain emerged and how severe it is and whether there are other symptoms associated with it and so on. Yeah.
All right, perfect. Thank you. Okay, are you happy if we move on to the second document? Okay, quick show of hands. How many of you have been to a consultation, had a fairly good consultation? thanked the doctor, walked out the door, heard the door close. Like, God damn it, I forgot to ask about such and such. Anyone? Ah, that doesn't happen. Who knew? Right, so the key is preparation. And so again, with patient's help and with an incredible guide in hand, that was Jenna this time, not George, we looked at appointment preparation. So lots and lots of parts to this. And again, this is duplicable. It's downloadable. It will be available in other languages. Sarcasm will be in the third trench of languages, but it will be available in sarcasm as well. Right. You open up the document and you're in the first page. Prepare your questions. Now you've got a nice big space in there and you've got some suggestions underneath. And again, the key is where you are in your journey. But pick 3. Right now, what are the 3 most pressing issues you face? Okay? It could be physical, emotional, it could be biochemistry, it could be histology, it could be symptom burden. But you know what? Let's talk about it. This was a mind-blowing piece of information the first time we heard this. Again, you'll probably remember this conversation because we came to you and said, right, what's the most helpful thing a patient can bring to the consultation? You said, well, actually, it would be really helpful to know which medications they're on. And I don't mean, you know, the wee blue ones. Or the wee black and white ones. I think they're 250s. No, they might be 7 foot. No, they're definitely, but they're black and white and they're about that size. Okay, on a scale of 0 to 10, how helpful is that information?
Just to interject here and say, I cannot tell you how frustrating it is when a person comes to a consultation and doesn't know their medications. It is incredibly infuriating that, you know, 25 years of my life invested in learning what medications people should be taking, and they can't even be bothered to tell me. So, you know, if you want to know what sort of people are feeling on the other side of the table, not knowing your medications actually is deeply, deeply frustrating. The medications, every single medication is there for a purpose, but every single medication carries the possibility of side effects and the possibility of interactions. And we as physicians need to know what you're taking before we can tell you what comes next, right? You know, for example, simple example, if someone has fatigue, and I discover as they go through their medications that they're on thyroxine, I instantly know that I need to check their TSH to find out if they're on the correct dose of thyroxine, and so on and so forth. So I'm really glad to see that the list of medications is included there. It's really, really important.
We listen. So come off the fence and tell us how you really feel about that. Yeah, okay, right. I love, we talked about this in the panel with industry. I love that we have these honest conversations, and because it makes the difference, it makes the changes. So you bringing that to us and going, you know, no, he was that polite when he said it first time. So, right, the other important piece of information is your symptoms. How are you actually feeling? I'm fine. Well, what the hell are you doing here then? Okay, talk. Let them know. And again, it's really, really helpful. Those of you that are using the app and they're able to record your symptoms on a daily basis, show the chart. And you can superimpose the different symptoms that you have, which will then maybe start to open up relationships. I think we said yesterday, the number of patients that say to us that a fatigue day always follows an itch day for them. And they're only able to look at that because they put the 2 symptoms on the same graph and watched. So use the app, but prepare your conversation and open up where you are with your symptoms. We have a question. Do we have a mic? Yep.
Hi, can I ask, why do we need to tell you which medications we're on when you guys and our GPs are the ones who prescribe them and it should be on our medical records?
Well, I mean, yes, in a perfect world, there would always be completely up to date, but the GP healthcare records are actually separate from the hospital records. Your hepatologist doesn't prescribe all of your medications. Most people, sadly, do accrue medical conditions as they age. So, for example, people with PBC might also have high blood pressure. They might also have diabetes. They might also have, for example, hypothyroidism. They might have other rheumatological conditions. There'll be a whole bunch of specialists involved in the care of that patient. Not every single doctor will be absolutely, will keep the records perfectly up to date. So the only person who really knows every single medication that they're taking is the patient. So there's that. The other aspect of it, though, is that you need, and I mean this with the greatest of respect to everybody in the room, these medications are toxins fundamentally. Every single medication has a therapeutic effect, but most of them carry some sort of side effect as well. You need to know what's going into your body. And the idea that someone can come to a consultation and doesn't know what's going into their body, these really important molecules, I find astonishing, and frequently say it, as I'm saying it now.
So, yeah. One of the reasons that made the app happen, and I won't name the hospital, but we were at a conference there, and there were 3 units on the same building that had entirely different computer systems. And that's not individual to just sometimes the way the NHS is built, they just use, and so they weren't talking to each other. And so actually it came to patients to use the app so that they had everything they needed to go from department to department that weren't talking to each other. So yeah, it's an imperfect world, and we do our best. So during your appointment, I think we've covered this. Are you happy? Yeah. You go through your bundle, you ask your questions. After your appointment, keep your notes in a safe place. Not a place so safe that you can't find them before your next appointment. Okay, so it's a relatively safe place. Dates for your diary, and obviously keep in touch with the foundation. If you have any questions, he said this, but what does that actually mean? Sometimes we can help with that, not always, but sometimes. And then you've got bits for remote appointments, and then you've got other useful resources. Again, show of hands, is that a helpful document? Yeah. Thank goodness for that. Congratulations, and thank you to the team for putting that together. Very grateful. Yeah, I think that is us. Are there any other questions that you haven't had the time to ask over the last couple of days? So we've got one here. Did I see a hand? No? Okay, that's fine. I was quietly hoping that Louise was going to come back because she has been an absolute legend this weekend. So if somebody could find Louise and bring her into the room, I'd love that. So anyway, ask your question, please.
I had a question about the slide that's just disappeared.
Yeah.
Which idiot put that on the screen?
Well, it's just that there's a lot. There's a reference there to hub hospitals and spoke hospitals, and I was just wondering what they are. And I mean, I think we're probably dangling off the pressure valve of the tire of the bicycle wheel of the spoke of the hub. So I was just wondering, how far away from actual, the coalface we are in our little hospital.
Yeah. I mean, this is what's known as a funnel plot, actually. And the idea of this funnel is it gives you an idea about whether the centers that are being investigated are performing at the average level or above average or below average. And what it shows really is that the really big centres, which are seeing lots and lots and lots of people with PBC, by and large, well, not by and large, actually, there's plenty of large hospitals that aren't performing pretty well, but the centres that are performing at above average levels are those that see the most patients, whereas the centres that are performing below average are the centres that see very few patients with PBC. That's what this shows. You know, I don't really know why Robert wanted to show it to you, but there we are. What a hub hospital was, you know, according to this graph, is just a centre that sees a lot of people with PBC, basically, and that'll be university hospitals, transplant centres, that sort of thing. Yeah.
Trained professionals. Right. Next question. Yes.
This is almost the same question, but I was just wondering, are the results of the national PBC audit available publicly so that we can have a look at our own specific area where we live to see what the results are in our location?
Not to that level of detail, no. I mean, the overall results have been published, and those are definitely available in the literature. Results for individual centres were not made publicly available. All results were returned to the centres that had participated, though. So at your next consultation, you could, for example, ask, how did this hospital do in the audit? And it may take a little bit of digging on behalf of the clinician, but they would have the results some way.
Okay. We're there.